Great, thanks, Doug, and welcome everybody. Hope you've enjoyed the day so far. This committee, chaired by Nick Talley and co-chaired by Vincenzo Stengolini, you can see it's a blue ribbon panel of experts in this area, and they're tackling a tough area. I mean, the reality is that there are no drugs that have been FDA approved for functional dyspepsia, or for that matter, any of the upper GI functional disorders. So they've been working diligently to think about how to optimize the criterion for these disorders, and particularly focusing on functional dyspepsia. Now, some of the key points that have come out of the discussions that have occurred so far are that the definitions of gastroduodenal disorders and relative subgroups, this is, by the way, initially, before today, they were largely saying that there was not going to be much change in regards to the criterion for functional dyspepsia, that they felt comfortable that the designation of the dyspepsia subgroups, epigastric pain syndrome and postprandial distress syndrome, if you recall, have been conceptually pretty widely accepted amongst investigators in gastroenterology, and that there was some epidemiological validation data to suggest that patients do segregate into these two dyspepsia subgroups. Now, let me just tell you that subsequent to my making these slides yesterday, the committee met this morning, and they still adhere to those concepts that I just said to you a moment ago, but they are talking about making some potential changes to the criterion. Specifically, they're debating right now about the utility of keeping the word functional in functional dyspepsia, or perhaps thinking about some other terminology that removes that term, which a lot of people view as pejorative and sort of confusing in regards to this entity of functional dyspepsia. Specifically, they're talking a lot about the possibility of really focusing on those subgroups and getting away from emphasizing that umbrella term. So in other words, thinking more about trying to focus in on the subgroups. And even along the subgroups, and this is very, very preliminary and based largely on discussions from today, one of the very interesting concepts that's being sort of thrown around right now is the possibility of separating upper GI symptoms, specifically the symptoms of functional dyspepsia, based primarily on whether they're meal-related or not. So in other words, meal-related postprandial symptoms related to motility abnormalities, like the typical symptoms of early satiety and nausea that have been associated with PDS, would actually be combined with epigastric pain syndrome if it's meal-related. So acknowledging that the pathophysiology of meal-related symptoms probably leads to a spectrum of different types of symptoms. Now, this is very much in debate, and it's by no means been codified, but it's an interesting discussion that will be ongoing for the next several months as they decide on how these criteria will look as in Rome 4. There would then be also a non-meal related symptoms category as well. So a bit of debate. It's by no means carved in stone. It may very well be that PDS and EPS will remain unchanged. On the other hand, it might be that the symptoms will be more aligned with whether they're truly meal related or not. Another issue that they're debating right now, and I think that they have reasonable clarity amongst the committee members anyway, is does the diagnosis of IBS trump other functional diagnoses, including functional dyspepsia? And I think that the way the committee's feeling about this right now, and it was subject to a fairly healthy debate actually when the committee presented to the larger group this afternoon, but the way the committee feels, and I happen to agree with this, is that most patients with dyspepsia have other GI symptoms. That I see a lot of people shaking their heads. The clinicians all know this, and I think it's one of the things that's gotten in the way of, by the way, designing and recruiting for clinical trials. I think it's the reason why FD trials are so notoriously hard to recruit for, is because almost everybody that has dyspeptic symptoms has some other GI symptoms, either GERD-related symptoms or lower GI symptoms. And so finding a pure dyspeptic symptom is challenging in clinical practice. And the way the committee is leaning right now is to potentially allow some of these comorbid, or at least to acknowledge how commonly comorbidity occurs. And of course, it would be up to the individual company to decide how they want to handle that within the auspices of their clinical trial design. Also, a very important topic that I think is a very interesting discussion has to do with the thresholds that would define the disorder. So in other words, what is the level of symptoms that an individual experiences that rises to the level that would be considered clinically significant? It's interesting that a lot of these thresholds to this point have been fairly arbitrarily set. And so what this committee is doing is taking a critical look at what evidence exists to give a better idea of as evidence-based threshold as can be determined as part of this process. And indeed, this was discussed broadly with the group, and I think will probably be done amongst many of the committees, many of the criterion committees going forward. One of the other things that's I think I'm going to skip that actually. I'll skip this for the sake of time. So some other things that they're struggling with and discussing right now have to do with what to do with H. pylori related dyspepsia. So in other words, do you exclude these patients and say they don't have functional dyspepsia, or are you more inclusive and acknowledge the fact that many of the patients, even when they have H. pylori, don't get better if you eradicate the H. pylori infection? So this is something they're sort of banting about right now. Also, they're synthesizing the newer information on some of the histological abnormalities that have been identified in functional dyspepsia subgroups. So, for example, Nick Talley's group has made an observation in several publications now about duodenal eosinophilia. Psychological features, again, and I think this is something that's this is one of the features where the multidisciplinary or the multidimensional clinical profile will really help us. So one of the things that's going to change with Rome 4 is the introduction of the MDCP, the multidimensional clinical profile, which will have a STEM diagnosis, modifiers, psychosocial modifiers, biomarkers, and what else am I leaving out?
Physiologic and impact.
Yeah, actually severity and clinical impact. But I think that this multidimensional clinical profile will allow one to very concisely be able to convey a patient's illness experience in a much more complete way than has been the case with the previous iterations of the Rome criteria. So again, I think actually the psychosocial distress will be one of the modifiers that people can add to this MDCP. And why do we think that's important? We think that's important because it potentially influences the type of therapy that you might choose or might add to a patient's treatment regimen when first evaluating them and making judgments in regards to the etiology of their symptoms. Another controversial issue that again I think they're getting clarity on has to do with this issue about gastroparesis versus functional dyspepsia. I think that the committee is coming down on the side that they're obviously distinguishable with the use of a gastric emptying study, but that in clinical practice most of the time a gastric emptying study doesn't get done. And then the last thing that I have listed here is that I've alluded to earlier is again whether or not the word functional will survive, or whether they might think about something like, for example, chronic idiopathic or some other terminology that gets away from the use of the word functional for this particular disorder. All right, let's see. In regards to things other than functional dyspepsia, they're actually discussing the best way to approach criterion for gastric versus supragastric belching, also within the context of aerophagia. And then nausea and vomiting disorders are likely to experience little change in Rome 4. That's sort of the prevailing feeling right now in regards to that. And then with rumination, they're going to carefully review and then discuss the latest information in regards to physiologic testing and biomarkers. Whether or not that'll actually rise to the levels that it might be included in the diagnostic criteria, I think is very unclear. I think it's actually unlikely, to be honest with you. But there certainly will be much more to discuss in terms of pathophysiological and translational studies in the actual chapter itself.